I'm John Gribben. Welcome to iwNHL 2018 in very sunny Nice. I'm joined by Stephen Ansell from the Mayo Clinic, Catherine Bollard from Children's Hospital in Washington, DC. So, a very interesting opening day. Beautiful weather outside, but a very full audience all day. So a lot of sessions. As usual, we started with what's become traditional now, the session on Tcell, non-Hodgkin's lymphoma. It's an area where I've always been struck over the last few years, just explosion in our understanding of the knowledge of the pathophysiology. Hasn't yet totally translated into improvements in outcome yet. Steve, any comments?
Yeah, I think you're right. I think it's exciting because genetic mutations, helping to really define a cell of origin, looking at variety of different predictive and prognostic markers. GATA3 was one that was highlighted as being a poor prognosis and really understanding that it defines the type of cell that the tumor is arising from. But as you point out, the excitement is about understanding the biology. The challenge is how to really be able to affect the outcome of patients. This still remains a challenging disease. But I think as with other diseases, as you understand more and more about the tumor, so you have better opportunities to exploit vulnerabilities of the tumor or augment the immune response and get a better result. So I think we're kind of poised for some good stuff.
Can I ask a question about enhancing the immune response against T-cell lymphoma? You know, generally T-cells are not good at killing other T-cells. So when you say enhancing the immune response, have you got particular sort of strategies in mind? Do you think T-cell therapy has a future here, or should we be really looking at other types of immune-directed therapies?
Yeah, so I think you make an excellent point, is that just simply having a general way in which the T cell does something is not helpful. And I think what we know is, for example, PD-1 blockade and preventing a suppressive signal is good and bad. So there's some patients that clearly benefit, but there are other patients where by taking off the brake really liberated the tumor cell. And so you actually have got patients that will rapidly get worse. And so, for example, in the acute T-cell leukemia lymphoma field, blocking PD-1 is actually a poor idea because the patients may do substantially worse. And I think in the field you're expert in, where you actually are using T cells that are infused to target malignant cells, just simply having a T cell that doesn't see something specific on the malignant cell is actually going to just be fraught with side effects and toxicities and problems. So I think our challenge is understanding, as I mentioned, the vulnerabilities of exactly what the T cell either has on its surface or has as a need, and then exploiting that.
Well, that's a perfect segue into the next section, which of course was on biomarkers. Now, of course, we had a whole series of talks looking at a variety of different biomarkers, which I guess we can think of in terms of looking at the biomarkers within the malignant cells themselves, or looking at the biomarkers in the microenvironment. But first, I'd like a little bit of a discussion with both of you about the question of when do we look for biomarkers? I mean, the issue I think many of us have is that quite often the biomarkers we have are looked at the wrong time. A lot of diagnostic samples, a lot of samples before the immunotherapy or before the chemotherapy is given. What's your general view about how we think about, particularly when we think about where we were with T-cell lymphomas a moment ago, how we think about one therapy no longer fits all, but starting to tailor therapies towards individual patients?
So I think biomarkers kind of come in a variety of different uses, if you like. So on the one hand, it's really helpful to have a good understanding about where the tumor came from, so that potentially we can pick therapies better because it may target a specific cellular subtype or the like. The challenge, however, is we also need predictive biomarkers that tell us how we're doing with therapy. And those are not helpful if you just do them at the beginning and never again. So we'd like to know that we're expanding cell populations that we care about, or we're down-regulating targets that we think are important. So that's where I think what you're alluding to is really important, and that is we need a better understanding of when to obtain the specimens. Because if you look too soon, you may miss the change you're interested in, and if you look too late, it may have already happened and you may have missed it. So I think there's a lot to be done to still understand exactly when to look for what.
And you know, for me, coming from the T-cell therapy field, I sort of feel we as a community have really focused on the immunobiological biomarkers. And I don't think we've talked enough to oncologists who have been more interested in the tumor biomarkers. And so we need to actually do a better job at utilizing a broad number of biomarkers and vice versa, right? I think that traditionally chemotherapists haven't really paid as much attention to what's happening in the immune system and paid more attention to the sort of cancer biology and biomarkers that side. So I sort of feel meetings such as this are great for bringing these groups of people together so we can look at novel and diverse biomarkers for a disease where now the landscape of how we're treating this disease is so different and much more immunotherapy focused.
Yeah, I guess the other thing I'm struck by when you start thinking about and the whole question of precision medicine is it's hugely exciting and think of the potential advances, but how do we actually get a drug approved when we start dicing a disease into smaller and smaller subsets and identifying the subset who are going to respond? And it isn't the classical way that we've done clinical trials. And do we have to think differently about how we do it? And how is that going to keep the cost of drug development down when we're going to end up having to do trials with huge numbers of centres to get smaller and smaller subpopulations of patients into these sorts of studies?
I mean, I agree with you. I don't think there's a right answer to that. So I think, that is a question for the field. I think this is something we're all going to have to struggle with as we, do these pivotal studies for these targeted therapies, whether they be immune therapies or whether they be small molecules. But we definitely, traditionally, I don't think we can think like the old days. We have to move outside the box in how we do these things.
I would say, though, that it has allowed us to get things approved when we've actually been a little bit more focused. Yes. Because, again, sometimes the signal is lost when you look at an undifferentiated population. So there's a sweet spot between focused sufficiently to get where you need to go, but not making it so focused that it isn't beneficial for a larger population of patients. And sometimes we also think we understand the biology, and so we get very focused, and we may actually miss things because the biology is maybe a little more convoluted than we might have thought.
Yes.
Complex, exactly.
Now, thinking of specific targets, of course, a very specific target would be a viral antigen. And you, of course, chaired what I thought was a really fascinating session on virally driven lymphomas. Is that how you think about it? This is a model system to be examining how you can target specific antigens that you believe will have much more broader implications as we start to think about other things.
So that's exactly right. So I think that session really sort of drove home the fact that here we are with these virally driven lymphomas, and don't forget about the virus. This is a perfect vehicle to target. It's perfect for thinking about preventive strategies. And so I think that's what we talked about in our discussion afterwards, is we should be thinking more about the virus, even in the HIV-associated lymphomas, where clearly they're doing what we heard from Rich Little today is patients with HIV-associated lymphomas are doing as well as patients with HIV-negative lymphomas. But this is an opportunity to not only include them in larger phase trials with all comers, but also an opportunity to think about how we can target the virus at the same time. And EBV is a great example of we can do a lot of manipulation of that virus to elicit an anti-tumor response. And you heard from Mark Rochelski discussing LYG, and Ruth Garrett talking about EBV-associated Hodgkin lymphoma. And while I was focused on HIV and EBV-specific T cells, I think the message that we all want to take away is that there should be a combination strategy. I don't think targeting the virus alone is going to do it. Targeting the tumor alone is going to do it. We have to look at this as a combined therapeutic approach.
And of course, that leads us perfectly onto the session where Steve and I talked about, which was focusing much more on a pure immunotherapy approach to cases in which the antigen is not well defined. And of course, we were just talking in our discussion about the issue of exactly that, about there's the microenvironment and there's the tumour, and you can't really think about one in isolation without the other. And we heard some strategies thinking about combining immunotherapy with chemotherapy. It's a little less sexy in many respects to be going backwards, but do you think that's the future, to be looking at targeting these, the two different cell populations in slightly different ways?
Yeah, I think it is, because I think much though we'd love to move on to the new novel next thing, it's important to realize that there have been real successes with chemotherapy, and we should build upon that. And I think the reason we should build on that is that the malignant cell is really defining the microenvironment. And unless your therapy specifically gets rid of the malignant cell, you're still going to struggle to be able to get the microenvironment to behave the way you'd like it to. So I think Rob Chen was sharing data which I thought was very interesting on brentuximab vedotin, which obviously directly targets the Reed-Sternberg cell, in combination with nivolumab, which is augmenting the immune response. So I think that combination is one of the ways to look to the future to kind of do things that target the malignant cell at the same time as modulate the environment.
Now, you also were talking about a whole variety of novel agents targeting other kind of checkpoint inhibitors. I guess I was struck by, when we were having the conversation about the biomarkers, and exactly that, is that which patient populations need which combinations, whereas we tend to do the trials of which patients come and try it. But have we come to the point where we need to start thinking a little more about carefully selecting which patients go on to which trials? Is that the right way to think about combination immunotherapy approaches?
I think it might be. I think it's still challenging because there's probably one additional area of complexity, and that is the cells we're trying to actually activate or utilize, what percentage of them are present? So when you're actually doing a dual immune checkpoint inhibition or activation and inhibition all at the same time, where is the population of cells that you're trying to activate? And you made a good point in Hodgkin lymphoma, where PD-1 blockade is highly successful. But if you say, where are those PD-1 positive cells relative to the Reed-Sternberg cells, there's another whole level of complexity. So is there a future where you would actually define where the target cell is relative to the malignant cell and pick those patients? I don't know. I hope we never get there. I hope it's much more simple than that. But I do think, as we're looking to combinations, simply just putting things together needs a rationale for why you're doing that, because otherwise we're going to have to do a lot of studies, many of which may be unhelpful.
So there you have it. I think what you're picking up from us today is we were excited by day one. I hope you're happy to hear how we discussed it, and we are certainly looking forward to day 2 of iwNHL 2018, and very happy to be in very sunny Nice. Thank you very much.